allow me to introduce Dr. Yanutsi and Dr. Omer Travisky are going to be our moderators. And the first talk is by Omer Travisky, Ophthalmic Artery Stenosis and AMD, Rethinking the Role of Ocular Perfusion in AMD. Take it away, Omer.
Thank you, Phil, Ari, and Tom for inviting me to give this talk. Today I will share our results of ophthalmic artery stenosis in AMD. But before I start, I would like to thank our research team in Bascom Palmer I'm very proud to be part of, and my everlasting mentor, Dr. Rutherford, who is here. And of course, our great collaborators in University of Washington from the Department of Bioengineering, led by Dr. Wang, my team at the Tel Aviv Medical Center, the Macula Center team, and of course, those who helped us to push this study forward, the Ocudyne team. So to the big question, what is the cause of AMD? We know that there is genetic risk factor, CFH and HKRA1, as well as aging, of course, which is the number one risk factors, and as more as other environmental factors. So let's start from the beginning. Our group has already shown that in healthy individuals, choroidal thickness decreases in size with age. Not only that, we know that choroidal capillary perfusion decreases with age as well as, specifically, the macular area. Here is an example of a percentage flow deficit in 26-year-old patient compared to 87-year-old patient, showing much more significant prominent flow deficit percentage in the older one. So as eyes got older, choroidal capillary perfusion deficit increases more in the central macula. And that is not entirely new. In 1975, Professor Eyre has already taught us that the macular region is especially vulnerable to chronic ischemic disorders. So what's the underlying cause for this relationship? In 1997, Dr. Friedman published his hemodynamic model of AMD in AJO. We further went ahead and updated this model in 2022. The choroidal perfusion arises from the carotid artery and the ophthalmic artery. In eyes without AMD, what's the relationship between those? This was published in the INFLATE study papers. That showed us that after surgery to the carotid artery, there is improved choroidal perfusion suggested by increased thickness, improved choroidal perfusion, decreased choroidal flow deficit, and these changes were consistent over a long follow-up. And this is just one example from the study of a 75-year-old man. To the left, the mean choroidal thickness maps, and to the right, the chorocapillary thickness maps. You can clearly see the difference in the choroidal thickness right after surgery in the surgical side compared to the non-surgical side, as well in the chorocapillary thickness maps, which increases. So in eyes with AMD, what's the vascular evidence for compromised perfusion? A study conducted in the Martino Centers showed correlation between severity of disease to the ophthalmic artery volumetric flow using a 7 Tesla MRA. We in Tel Aviv followed this study with a 3 Tesla MRA following 50 AMD patients, wet and dry. In this study, we used the time of flight scan, which visualized the blood flow without contrast by relying on proton movement. A specialized protocol was developed specifically to target the ophthalmic artery. To the left, you can see an example of the standard 3 Tesla time of flight protocol, and to the right, with the error, our customized protocol was the course of the ophthalmic artery is clearly identifiable and measurable. There was a clear grading protocol for the ophthalmic artery in 7 specific points, and it was bound by 2 blinded graders with third adjudicator. Almost 90% of the patients had ophthalmic artery stenosis worse than 30%. Severe ophthalmic artery stenosis above 50 was more common in dry AMD, and if we try to explain it, it seems that wet AMD was more often associated with moderated stenosis. Just a theory suggests a possible threshold where mild to moderate ischemia promotes VEGF production, while chronic ischemia eventually leads to atrophy and GA. There was significant correlation between percentage of stenosis and larger area of GA and decreased choroidal thickness. Here is an example of a 76-year-old male with GA in both eyes. The left eye demonstrates a more severe state of GA, both in terms of lesion size and a noticeable higher pigment burden, which is clearly higher in the left eye. To the left, you can see a reconstruction of the ophthalmic artery path from the internal carotid to the orbit, and to the right, a 3D render of the arteries with arrows showing the ophthalmic artery, right in yellow, left in purple. Our radiologist measures the stenosis over the road of the ophthalmic artery. The numbers are not what we are used to from Doppler and will eventually need adjustments. The summary of the measurement is shown in the table above. MRI imaging reveals a more stenotic ostium of the ophthalmic artery to the left, which is also evident in the flow structure. Measurements indicate significant greater stenosis, which could potentially translate into reduced perfusion of the choroid capillaries and serve as a trigger for a faster disease progression. Taking you back to our paper published back in 2023 in Ophthalmology Retina, where we showed that AMD is actually an asymmetric disease. The eye asymmetry was shown in very early drusen stage. What could actually explain this asymmetry in late AMD? Considering both eyes age is the same and have the same genetic risk factors, what could explain this asymmetry? Ocular perfusion. So choroidal perfusion does not cause AMD. It just pushes the risk forward. A feasibility study is undergoing and we will soon hear, and we ought to be smarter very, very soon. So decreased choroidal perfusion occurs with aging. Decreased choroidal perfusion does not cause AMD. Decreased choroidal perfusion exacerbates AMD in genetically at-risk individuals. Genetics load the gun and environment pull the triggers. Thank you very much.
Excellent talk. Thank you. How do you think we're going to be able to roll out a treatment like this if it becomes widely adopted? I mean, it seems like a challenging procedure to be able to reperfuse patients at risk at this. And second question I had was, do you think some of your findings also applied to what we see in choroidal ischemia in, say, a myopic degeneration patient who's developing atrophy? Do you think those patients are at particular risk of malperfusion?
Okay, so first of all, there is a company that we will talk probably just right after me, trying to move this procedure forward and trying to catheterize the ophthalmic artery. Of course, we're in the very beginning, and eventually we'd have to, to go through the diagnosis of the ophthalmic artery and to find a better way than MRAing every AMD patient that we had. Otherwise, the MRA, department will be exploded with patients. But we're in the very beginning. As for myopic, so I can't really answer that. I mean, eventually we did this study in AMD patient that's like a specific cohort. Eventually we need to go forward and discuss and learn more retina patients because it seems like perfusion matters not just in AMD.
Any questions from the chat?
Nope. I think we should move on.
Let's move on to the next talk. So for the next talk, it will be Mario Saravia discussing a feasibility study of balloon angioplasty for the treatment of ophthalmic artery stenosis in patients with geographic atrophy. Take it away.
Thank you for having me in this meeting again. It's a pleasure to be invited and to share with these iconic colleagues this meeting. Well, in the 2024 edition of this meeting, we discussed our ongoing project. It was a crazy idea to perform ophthalmic artery angioplasty in patients with geographic atrophy, in whom occlusion was detected via MRI. In the following edition, last year, we presented the 6-month results of those 11 treated patients. In that data were published in a neurosurgical journal last year. Patients showed significant gains in visual acuity. There was an average gain of 7 lines. They jumped from 28 letters to 35 letters, which contrasted sharply with the lack of changes in the contralateral eye, which was also affected. As you can see in this graphic, in blue, the study eye, and in orange, the fellow eye, that is 6 months follow-up. But we also observed an increase in choroidal thickness in the study eye, while no changes were noted in the fellow eye. So 24 months after that angioplasty, I wonder what was planning for that. A study with a larger N sample size is planned. However, a long-term follow-up of the initial cohort was not originally scheduled. Many patients began reporting a decline in their general vision. What concerned me a lot, we know that the effects of coronary angioplasty last about 2 years in coronary arteries. Would the same hold true for smaller vessels like the ophthalmic artery? I wondered what was going on. So, from my personal initiative, we assessed 9 of the 11 patients. Out of the 11 subjects, 1 patient died, and the other is living in Aruba, so she couldn't come to Buenos Aires. And we only assessed visual acuity and choroidal thickness. And these are the results. Visual acuity declined a little, but still are 5 letters above baseline. And choroidal thickness returned to baseline, but compared to the fellow eye, it was a great performance. So it's something that we really raise many questions from this data, and I hope you have more questions than mine. Thank you very much.
So, Nico, Mario has a little connectivity issue.
Okay.
So I'll just fill in and say that this is an ongoing project. It's a safety project, and it appeared to be safe. So in Buenos Aires, they're continuing on with a pivotal trial, and we're in discussions with the FDA now to get a feasibility study started in the US. And in the chat, there are questions of the impact on the choriocapillaris. Unfortunately, in the clinical trial in Buenos Aires, they didn't have a swept source OCT. However, for the pivotal study, there will be an IntelLight swept source OCT, and we'll get an idea of just how the choriocapillaris and choroidal thickness changes, just as Omer Tversky showed with the carotid endarterectomy.
Excellent. Okay, let's move on to the next talk, which will be by David Zaks, Fast Inhibition with Z-lafacetolide, a novel approach for the treatment of geographic atrophy.
Hi, My name is David Zaks. I'm the co-founder and chief scientific officer of ONL Therapeutics. Today I would like to talk to you about inhibition of the FAST receptor as a treatment for retinal disease and geographic atrophy in particular. ONL Therapeutics is a clinical stage biopharmaceutical company based out of Ann Arbor, Michigan and the University of Michigan, where the technology was developed. We are executing on our mission and living our values to help us achieve our goal of helping patients see the future. Today I will talk to you about the use of zelafacilitide, which was formerly known as ONL-1204, and its use in geographic atrophy. Zelafacilitide is a 12 amino acid peptide that is delivered intravitreally and inhibits the FAST receptor. Why target FAST? Well, FAST is a very upstream activator of two critical components of the disease. When the FAST receptor is activated, it turns on death signaling cascades, including apoptosis, necroptosis, and others. In addition, and just as importantly, activated FAST turns on the inflammatory cascade, resulting in the production of cytokines and chemokines. This inflammatory cascade is critical in the propagation and perpetuation of disease. Blocking FAST prevents not only death signaling activation, but also attenuates the inflammatory cascade and the inflammatory response seen in disease. At ONL Therapeutics, we have a robust pipeline and applications for FAST inhibition. Today I will focus on geographic atrophy. Recently, we conducted a phase 1b study using zelafacilitide, formerly known as ONL-1204, in geographic atrophy. This study had two components. In the first part, we did an open-label dose escalation study. Patients with geographic atrophy received a single dose of zelafacilitide, starting at 50 micrograms and escalating up to 200 micrograms. Patients were then followed for 6 months. In the second part of the study, patients with GA were recruited and their rate of GA lesion growth was monitored for 6 months. At that point, they were randomized to either low dose, high dose, or sham. They received an injection, and then they received a second injection 3 months later. They were then monitored for an additional 3 months. So what did we find? First, zelafacilitide was safe and well tolerated. Most AEs, or adverse events, were mild and procedure-related. There were no cases of CNV or intraocular inflammation. What about efficacy signals? In the first part of the study, the open-label dose escalation component, we did not have a control or a sham group, but we did have the fellow eye. When comparing the growth of the GA lesion in the treated versus the fellow eye, a single injection of zelafacilitide resulted in a 42% reduction in lesion growth measured at 6 months. We also saw a few letters of vision gain in the study eye versus the fellow eye. What about in the second component of the study? Here we did have a sham treatment arm. We see that during the treatment phase of the study, the lesions in the sham group grew by 1.8 millimeters squared per year. This was reduced by up to 50% in the 200 microgram treatment arm. When looking at vision, we saw that over the course of the study, patients in the sham arm continued to lose vision, while patients in the zelafacilitide arms had stable or even slightly improved vision. From a mechanism of action perspective, does this make sense? Does this pass the gut check? Remember that I told you that blocking the FAST receptor does two things. It blocks cell death, and it attenuates inflammation. We believe that blocking cell death is represented by the reduction in the rate of lesion growth. Reducing inflammation is what may potentially allow the retina to function better and allow for improvement in vision. These results gave us the confidence to proceed with our current phase 2 trial of zelafacilitide in the treatment of patients with GA, what we're calling the GALAXY trial. This trial is being conducted in 13 countries across North America and Europe. We are recruiting approximately 324 patients. They will be randomized to either a low dose or high dose every 3 months, a high dose every 6 months, or a sham. In the US, we will have a reference arm using Izervay. The primary endpoint will be the rate of GA lesion growth at 12 months, though the study will be carried out to 18 months. In summary, we feel that zelafacilitide offers a well-differentiated mechanism of action, and that by blocking FAST, we can block the upstream activator of both cell death and inflammation. Zelafacilitide has the potential to have both functional as well as anatomic benefits with reduced patient burden, with an injection frequency of every 3 to 6 months. The Galaxy study is now enrolling, and we thank all the study sites, doctors, and patients who are participating. Thank you very much.
Thank you. So we're looking forward to the phase 2 results. The time limit's been reached, so we're going to ask our audience members to chat directly with Dr. Zaks, and we'll move on to the next talk, which will be by Ann Fung, a one-time intravitreal VOI 101 for geographic atrophy, phase 1 update of a novel complement regulating gene therapy for non-neovascular AMD.
Thank you, Phil, Harry, and Tom, for the invitation to share our data at Angiogenesis. On behalf of the co-authors, I am pleased to share updated data from the Phase 1 trial of VOI 101, a one-time intravitreal gene therapy for non-neovascular AMD, including geographic atrophy. While age is the number one risk, we know that several GWAS studies confirmed that AMD is strongly associated with abnormalities on chromosome 1 and 10. Recalling angiogenesis in the late 2000s, there were many talks on AMD genetics, including Greg Hageman's 2008 talk that shared his team's work confirming a risk locus on chromosome 1 as causal in AMD. His team continued with donor eye natural history and gene expression studies to establish the genetics of why people get AMD, and most importantly, why others do not get AMD. This led to the discovery of the protective CFH haplotype. Protective genetics dictates C3b regulation and adherence of CFH to the RPE surface, where it confers protection from MAC deposition. The difference between risk and protection is a single amino acid switch, histidine for tyrosine. A genetic study of 4,000 patients showed that even one protective CFH allele reduces the risk of developing AMD by a factor of 4. Looking at the complement cascade, risk CFH is less effective at regulating the amplification loop, resulting in higher levels of C3b, C5, and MAC complex formation. In the histology section of a CFH risk AMD patient, you see extensive green C3 staining. In contrast, protective CFH shunts excess C3 into the decay pathway, thus reducing MAC formation. This age-matched control with genetic protection does not show C3 staining. VOI 101 is a one-time intravitreal AAV2 gene therapy delivering protective CFH protein to restore retinal complement regulation in AMD. PBI AMD 001 and 002 are parallel dose escalation studies that evaluated 6 doses of VOI 101. The steroid regimen included subconjunctival dexamethasone and topical difluprednate or prednisolone acetate. 24 subjects were enrolled with demographics and baseline characteristics representative of a typical GA population. 54% have completed 2 years with a mean follow-up of 586 days. Systemically, there have been no dose-limiting toxicities, IP-related serious or systemic adverse events, and no deaths. VOI 101 has been well tolerated. There have been no observations of steady eye vasculitis, retinitis, or choroiditis, pigmentary changes, optic neuropathy, or CNV. A low incidence of steady eye steroid response IOP increase was observed and managed with topical IOP lowering agents alone. A few inflammatory events were first seen in month 1 and were mild, transient, and controlled with topical steroid. There has been no recurrence of inflammation following the steroid taper. 2 patients had CNV in the fellow eye at baseline, and 1 fellow eye developed CNV at month 9. No steady eyes have developed CNV. With gene therapy, the question after safety is about transgene expression. In our target doses, we have found strong expression with aqueous CFHT levels through month 12 that are 10 to 13 times higher than baseline. In conclusion, in phase 1 studies, VOI 101 has been safe and well tolerated in all 24 patients across 6 doses, with a 10 to 13-fold increase in CFHT expression at month 12 over baseline. This one-time IVT gene therapy that delivers the key regulator of complement to GA patients is now being studied in the phase 2 Journey trial. Thank you to the phase 1 patients, investigators, and study teams. Phase 2 is now enrolling at these sites, and we look forward to sharing further updates as the development program progresses. Thank you.
Excellent talk. So what we have available right now that's FDA approved focus on blocking something in the complement cascade. This is simply adding something back that may be helpful. Do you feel that because of this, it makes it more sense to go straight to a gene therapy approach than to, say, some type of an injectable approach?
We do. We have extensive experience with the injections, and we know that there is always a bolus effect. You get a high level that gradually decays, and you're aiming generally for an exposure somewhere in the middle. So at times you're overexposing or underexposing. With a gene therapy, we can match the body's production of C3 and hopefully regulate it and keep shunting it into the decay pathway and also protecting the surface of the RPE.
Omer, you have a question?
Quick question. And that's not the first time CFH is being studied. And there was another company, Gemini, that actually tried to study CFH, and they did not, reach the primary endpoint. Can you say what the difference is?
Sure. As I said, Gemini was a full-length CFH neutral form bolus injection. This is the continual delivery of the protective, and we are out of time. But thank you.
Okay. With our next talk, it will be inflammasome inhibition with camuvidine K8, a phase 2 clinical trial in bilateral geographic atrophy by Jay Ambati. Take it away.
Hello. I thank the program committee for the opportunity to present results of our phase 2 clinical trial of camuvidine K8, a novel inflammasome inhibitor in patients with bilateral geographic atrophy. Here are my disclosures. Of note, I am a co-founder of Inflammasome Therapeutics. Our discovery that a class of anti-HIV drugs also blocked inflammasome activation led us to develop rationally modified derivatives called camuvidines that eliminated the parent molecule toxicity but retained inflammasome inhibition. Two of these drugs, camuvidines K8 and K9, are now in clinical trials for various ophthalmic and neurological diseases. In numerous preclinical models, including complement-mediated toxicity, camuvidines preserve both retinal structure and function. Today, I'll describe 3-month data from a multi-centered phase 2 US-based clinical trial of K8 in bilateral GA. K8 bioerodible implants are injected using a 24-gauge in-office injector at baseline and again at month 3 with an independent masked reading center grading lesion size over 6 months. K8 is injected in the eye with worse BCVA, and fellow eyes with GA are the control group. This fellow eye design maximizes statistical power by reducing variability between groups. Fellow eyes are the most robust control group in GA because treatment and control groups are identically balanced in factors that are known to influence GA lesion growth, such as genetics, smoking, and diet. They're also identically balanced for other clinical and socio-demographic factors that affect GA development. GA natural history studies have repeatedly shown very high correlations in lesion growth between fellow eyes of bilateral GA patients. This is in stark contrast to the huge variability in lesion growth between different patients. Phase 3 GA trials of approved products also showed nearly identical lesion growth in sham treatment group patients, regardless of whether their eyes were simply touched with the needle hub, the so-called sham group, or whether they were observed without treatment. The difference between 4% and 5% for the two sets of trials. So there was no difference in lesion growth between sham and no treatment. And the efficacy of one of the approved products at 12 months was virtually identical whether it was compared to sham group eyes or untreated fellow eyes, 17% or 16%. So the use of fellow eyes as controls is not only valid, but also quite robust. In the K8 trial, typical GA trial eligibility criteria were employed. The baseline demographic characteristics were naturally identical between treatment and control groups. Importantly, the groups were identically balanced for these factors that affect GA progression rates that you see in bold. Thus, the two groups were exquisitely well matched. The baseline FAF patterns were also identical. Lesion topography and locality were well balanced, as was the frequency of reticular pseudodrusen. Importantly, however, K8 treated eyes had larger baseline lesion sizes, and indeed in 70% of patients, the K8 treated eye had the larger baseline lesion size. So at the very outset, the deck was stacked against K8 because larger lesions on average grow faster. Despite this handicap, K8 was 3 to 4 times more effective than the two approved GA drugs at reducing GA lesion growth regardless of how the data were analyzed. Measuring the change in lesion size from baseline to month 3, either in millimeters squared or in square root transform millimeters, K8 reduced growth by over 40% compared to control. compared to only 10 to 14% or worse for the 2 approved drugs at month 3. Measuring percentage change in lesion size from baseline to month 3 using geometric mean ratios, either in millimeters squared or in square root transform millimeters, K8 reduced growth by 46 to 50% compared to only 13 to 16% or worse for the approved drugs at month 3. K8 also exhibited a much more rapid onset of meaningful efficacy than the approved drugs. Specifically, the time needed to reduce the mean lesion extension by 50 microns when compared to controls was over 14 months for one of the approved drugs, nearly 11 months for the other approved drug, and less than 3 months for K8. This shows us that not only does K8 have robust efficacy, but that it works right out of the gate. Within patients, lesions in the K8 treated eye grew slower than those in the fellow untreated eyes in 80 to 85% of patients, analyzed using either change in lesion size or percentage change, and using either millimeters squared or square root millimeters. Given the high correlation in lesion growth between eyes in bilateral GA, these K8 response rates were highly significant. The K8 responder rate was also very high when comparing treatment groups in their entirety. Using the approximate 20% lesion growth reduction at the month 12 benchmark of the approved drugs, K8 reduced lesion growth by more than 20% compared to the control group in 85% of patients, and reduced lesion growth by more than 50% in 65% of patients. So the response to K8 was broad-based. Importantly, K8 exhibits a clean safety profile with no exudative AMD, posterior segment inflammation, or optic neuropathy. These graphs show superior efficacy of K8 when compared with the approved drugs, 4 times the benefit with 1/3 the injections in millimeters squared analysis, 43% for K8 versus low to mid-teens for the approved drugs. In square root transform millimeter analysis, 3 times the benefit with 1/3 the injections, 41% for K8 versus teens or less for the approved drugs. Using geometric mean ratio analysis of percentage change in lesion size in millimeters squared, K8 efficacy was 50% compared to 13% for the approved drugs. And in square root millimeters geometric mean ratio analysis, K8 efficacy was 46% compared to mid-teens or worse for the approved drugs. We know that BCVA is highly variable, noisy, and subjective. Still, we're encouraged that K8 treated eyes exhibited vision stabilization compared to control eyes. Note that in the first 6 months of the phase 3 trials of one of the approved drugs, drug-treated eyes actually lost BCVA faster than controls. The data to date demonstrate a superior risk-benefit profile for K8 compared to approved drugs in mechanism, efficacy ceiling, treatment burden, and safety. In summary, we're encouraged that K8 is expanding the therapeutic ceiling in GA without increasing the safety risk. Phase 3 studies of K8 in GA are being planned. Thank you very much.
Excellent talk. Certainly a novel mechanism of action, as well as very positive results regarding the durability of your drug. What is planned for phase 3? What will you be comparing to as the comparison arm? Will it be Syfovre, Izervay? What do we have to look ahead to?
Yeah, so obviously thanks for the question, Nico. We'll obviously be aligning with the regulators on what they ultimately wish us to do. So those discussions will happen this spring.
Frank, you have a question?
Yeah, Jay, fascinating approach, fascinating results. Just wondering about the pharmacokinetic data, how you keep the dosing up in the eye, and would it be repetitive every 3 months?
Yeah, so we can tune, Frank, the length of the implant to make it 6 months, 2 months, 3 months, whatever we want. In speaking with our colleagues, 3 months was felt to be a good interim injection framework. And so that's what we decided to go. We know that the duration of release is roughly 2.5 to 3 months. And so that's how we designed this trial based on that.
Thank you.
Jay, fabulous results. What's the FDA saying about bilateral eyes and using fellow eyes as control? We're all waiting to hear from them. What's been your experience?
Yeah, so it looks from the talks from your group and others over the past session, it's clear that that's a very robust approach. As you know very well, it's not merely about efficacy. I think at least in the prior regime, the FDA has been interested in at least 300 eyes treated with the approvable dose or higher for safety considerations. So regardless of whether a 50-eye trial, as some approaches earlier today have shown, can show efficacy, I think that is unlikely to pass muster.
Congratulations.
Thank you.
Okay, we're going to move on to the next talk. Once daily zervimazine as a treatment for geographic atrophy, results of the phase 2 MAGNIFY study. Roger Goldberg will be speaking.
Thank you. I'm happy to be presenting the results of once daily oral zervimazine as a treatment for geographic atrophy, results of the phase 2 MAGNIFY study. I was an investigator in this study, which was sponsored by Cognition Therapeutics. The sigma-2 receptor, also known as TMEM97, is a membrane-bound protein and localizes in multiple subcellular organelles, including endoplasmic reticulum and lysosomes. It plays an important role in cholesterol homeostasis, lipid and protein trafficking, neuronal signaling, cell proliferation and death, and importantly for us, is expressed in the RPE, retinal ganglion cells, and photoreceptors. Zervimazine, previously known as CT1812, is an oral small molecule modulator of TMEM97 and prevents amyloid beta oligomers from attaching and being internalized into neurons. This can help maintain cellular homeostasis, including vesicle trafficking and autophagy, that is often disrupted in degenerative diseases where cellular stresses can lead to cell dysfunction and death. There is substantial preclinical evidence that suggests zervimazine may be helpful in dry AMD. I'll quickly go through some of the highlights. First, zervimazine has been shown to rescue RPE lysosomal trafficking deficits, which may help prevent loss of photoreceptors. This has been demonstrated both in a transgenic mouse model featuring amyloid beta accumulation, as well as in ex vivo human RPE cells exposed to amyloid beta or hydrogen peroxide, the effects of which were reversed when also exposed to zervimazine. Two additional studies showed that TMEM97 regulates the expression of various inflammatory cytokines in retinal diseases, and that a TMEM97 knockdown was protective against dry AMD. Similarly, in a mouse model, TMEM97 modulation was shown to restore photoreceptor layer thickness and reduce the accumulation of toxic byproducts in the RPE. Cognition has run 2 placebo-controlled trials in both Alzheimer's and Lewy body dementia and analyzed the CSF protein expression in these patients after 6 months on therapy. A Metacore pathway analysis of the differential protein expression in the zervimazine-treated versus placebo-treated patients highlighted geographic atrophy as the top disease ontology, with AMD overall being number 6. Finally, zervimazine shows good penetration at therapeutic levels in both rats and non-human primates in both the retina and brain. It has a peak plasma concentration 2 hours after oral administration, a half-life of 11.5 hours, and is metabolized through the CYP3A pathway. Because of this metabolism, there are elevations in LFT with exposure, and this is a dose-dependent effect and reversible on cessation of therapy. The 200 milligram daily dose was selected for the MAGNIFY study. Here we see the overall clinical trial design of the MAGNIFY study, which randomized patients with both foveal and non-subfoveal geographic atrophy 1-to-1, either 200 milligrams daily or placebo, with the primary endpoint being change in GA lesion area on fundus autofluorescence. The original plan was to enroll 246 patients with the expectation of getting data on 180 of them and following them for 2 years. Unfortunately, due to a strategic business decision by Cognition Therapeutics to focus its resources on Alzheimer's and Lewy body dementia, only 100 patients were enrolled and 89 patients were part of the full analysis set. You can see here that 64 of those patients made it out to 7 to 12 months of treatment, and 32 patients were 13 to 18 months of treatment. But I did want to share these results with what we know so far. Here are the baseline characteristics of the enrolled patients. We see roughly 77% of patients had subfoveal involvement at screening, and the average lesion size was about 6.5 square millimeters. Here's the overall top-line results using both a slope analysis and observed area analysis, which showed a 29% and 28% reduction in GA growth at month 18. The number of patients included at each time point is shown at the bottom of each graph, decreasing from 87 to 64 to 32 patients at months 6, 12, and 18. The square root transformation to adjust for baseline lesion size differences shows a similar result with a 24% reduction over 18 months. Looking at just the 32 patients who were on therapy for more than 12 months, and that shows a very similar result with a 24% reduction in GA lesion growth by month 18. A post-hoc analysis looking at the growth rate by 6-month segments showed an increasing effect over time, with a 12%, 18%, and 52% reduction in growth from months 0 to 6, 6 to 12, and 12 to 18, respectively. What about looking at photoreceptor changes on OCT? Here, while we can still detect a trend, it is less clear-cut, with an 11%, 9%, and 13% reduction in total EZ attenuation over 6, 12, and 18 months of treatment. This was not statistically significant. There was no change in best-corrected visual acuity over the course of the study, although numerically there were more patients in the placebo arm that lost both 10 and 15 letters at these various time points shown here. Zervimesine was overall well tolerated. There were no conversions to wet AMD in either arm of the study, and 4 patients experienced a significant elevation in their LFTs, though these were reversed on cessation of the medicine. The most common treatment-emergent adverse event was elevations in the LFTs, and the overall adverse event profile was similar to prior zervimesine trials. In summary, we have a strong scientific and preclinical rationale for targeting the sigma-2 receptor and evidence that once-daily oral zervimesine is able to reach the brain and retina. The phase 2 MAGNIFY study was terminated early, but in the eyes where we have follow-up, there is some evidence suggesting an anatomic benefit in patients with GA. Unfortunately, the company made a business decision to focus their limited resources on Alzheimer's and Lewy body dementia, but they are open to potential partnerships to further the development of this asset in AMD. Thank you.
So what do you think about the 10% rate of LFT elevations? Is that something that could be a potential blockade for this to move forward, or do you think it's doable with a dose adjustment or something in the next phase of development?
It's a great question. Look, in retina, we're used to directly administered therapies, not systemic therapies. And so we have a different comfort level with systemic adverse events, which I think our colleagues in the rest of medicine are frankly used to dealing with. I think it would be a hurdle to get retina specialists kind of comfortable with having to check liver enzymes and potentially stop the medicine, for those who demonstrate an increase in the LFTs.
So, Roger, I have a question. So, apart from those 10% LFT incidents, roughly 55-60% underwent attrition over 18 months. What was the principal cause for that?
Well, the attrition was just the trial was literally stopped in the middle of the study, unfortunately. So the reason for the quote unquote attrition was just the study ended, patients came in for a last visit,
Right.
and the study was terminated. So, it's a disappointment for those of us who are very involved in GA research, because here we had 100 patients who were committed to helping to investigate a new therapy for geographic atrophy. I do think an oral was frankly would be well received. The idea of being able to treat both eyes at the same time is, I think, quite appealing to patients. The trial enrolled actually quite quickly, and the company was forecasting its cash flow, and basically had to make a decision to focus its resources on Alzheimer's and Lewy body dementia, and terminated it really out of the blue. So this along with the NGM reading issue from a couple years ago, I look at as real disappointments in GA.
Thank you. So we'll move on to our final talk of the session, which will be vision restoration with the Prima system in geographic atrophy due to AMD by Frank Holtz. Thank you.
Thank you for the opportunity to report on behalf of the Primavera study group on the Prima neurostimulation system in patients with geographic atrophy. These are my financial disclosures. Most current treatment, as we already heard today, look at slowing disease progression over time without visual improvement, and especially in patients with loss of the fovea in geographic atrophy, it's a huge unmet need to restore vision in those eyes. The Prima neurostimulation system includes glasses with a camera and a projection module, a pocket processor, and the actual subretinal implant. The captured image is processed and projected onto the implant by near 880 nanometer infrared light, and the photodiodes in each pixel of the subretinal implant convert light into electric current to stimulate the still functioning inner retinal neurons. Each pixel comprises the active electrode in the center. The implant itself is 2 by 2 millimeter in size, 30 microns thick, and composed of 378 pixels of 100 microns width. The fundus photo and OCT on the right side shows the postoperative findings with the subretinal chip located in the center of the geographic atrophy lesion. This video depicts the surgical steps for the implantation, the standard 3-port vitrectomy. Then a bleb is formed, and by a retinotomy temporal to the macula, the chip is inserted under the retina. Perfluodecaline then flattens the retina, and the tamponade is used, oil or gas, and then the system basically can be used post-surgically by the patient. After the surgery, it's important that a quite intense rehabilitation program is being conducted with the patient over at least 12 months' time, whereby the patient learns how to use the system in daily life. Following extensive preclinical testing, small first-in-human clinical trials prior to the Primavera study were performed, looking at the feasibility of vision restoration with the system in patients with geographic atrophy. In these initial small studies, visual acuity improved compared with baseline, here shown for 3 patients, and prosthetic vision with the Prima glasses was better than the natural vision without Prima glasses. Here, the best improvement was 32 letters on the BCVA ATDS visual acuity test. Here, over a longer period of time of 3 years, the OCTs are shown, and there was no evidence of thinning of the inner retinal still preserved retinal layers. Here's a histopathologic finding in a patient who deceased, and here the chip was explanted, and it overall shows good biocompatibility with no signs of encapsulation or inflammatory reactions surrounding the subretinal implant. Following the initial studies, a prospective single-arm multicenter clinical trial, the Primavera study, was conducted in a total of 38 patients with foveal geographic atrophy. This was performed at 17 clinical sites across 5 European countries. Patients had to be 60 years or older and a best corrected visual acuity of 20/320 or worse in the study eye. The mean age was close to 80 years, and the mean total atrophy size at baseline was 24.8 square millimeter. The visual acuity problem with predefined threshold of logMAR 0.2 was found to be statistically significant. 81% of study patients had an improvement of logMAR 0.2. Here BCVA is shown at baseline 6 months and 12 months, expressed in both logMAR, the primary y-axis to the left, and letters, the secondary y-axis to the right. Overall mean improvement was 25.5 letters. The best improvement was 59 letters, and when participants did not use Prima glasses, there was no change found in visual acuity from baseline. Participants, importantly to note, dynamically adjusted zoom settings up to 12-fold during visual acuity testing. Here are the device or procedure-related SAEs at 12 months. 26 of device and procedure-related SAEs were reported. 21 occurred within 2 months of the Prima system implantation, of which 20 resolved within 2 months of occurrence. 22 were classified as mild or moderate. 5 participants had peripheral retinal breaks. All were treated intraoperatively, and none resulted in rhegmatogenous retinal detachment. Here are just a few examples of the use of the Prima system by patients in daily life, including reading or recognizing signs displayed in a train station. In conclusion, subretinal implantation of the wireless Prima microchip in patients with geographic atrophy is feasible. It can restore central vision and actually improve visual acuity in these patients who lost foveal vision due to GA. Prosthetic center vision provided by the photovoltaic system enable patients to recognize letters, sequences of letters and words. And obviously this is an important starting point, and the next generation of implants is aiming at an even improved resolution, a larger chip with a larger visual field, and also improved glasses. The results have been previously published in the New England Journal, and the article was accompanied by a well-written editorial by Jackie Duncan. Thank you.
Thanks. Excellent talk. One of the slides you showed showed a participant's choice arm for the vision. Can you talk a little bit more about what that meant?
Yeah, the system was tested being switched on and switched off, and so the patient had a choice as if he felt an improvement by using the actually implant when switched on. So it was again tested against non-functioning, basically.
So were there any patients in that arm that preferred to have the implant off or saw better with the implant or the implant turned off?
Well, again, I pointed out it needs a rehabilitation time that is needed so that the patient learns with it. And initially, there are always some hurdles for them to be trained to use it. But in the end, they all use it as a matter of fact.
David Zaks has a question.
Yeah, Frank, great technology, very exciting. What is the field of vision with this implant and camera system, and how much training do they need? Do they scan to read? Can they really follow a line on a page or things like that?
Yeah, David, excellent question. Obviously, it needs that training. It's a very small visual field, 2 by 2 millimeter is the actual chip. And again, as a starting point, now we are aiming at increasing the size of the chip to increase the actual visual field. But as you point out, it being a small field, it's not a fluent reading, if you will, but they really have to scan along the lines, along the letters and words.
Very exciting. Thank you.
Who's going to be the right patient for this type of device? And how do you compare it to, say, a stem cell approach?
Yeah, actually, question, Nico. Basically, stem cells, I think it still needs to be shown that it improves vision and especially restores vision in areas where there's a total geographic atrophy, though. So the patient, it needs to be one in obviously with bilateral geographic atrophy. And for future patient selection, it may need patients highly motivated to go through the training and do that. And obviously not all the patients would qualify for that type of treatment approach then, but patient selection will be key.
Okay. Thanks to all our session 4 speakers and panelists, and to my co-moderators, Dr. Rosenfeld and Dr. Travitsky. Don't forget to visit the virtual exhibits. Just click on the exhibits link in the meeting site. If you've not already done so, please take a minute to complete the pre-test that will be sent by email. We will follow up with a post-test tomorrow after all lectures are over. Please send your questions through the chat panel to the right of your screen. If your window video is maximized, you may not see that chat panel. Just minimize your video temporarily and type in your question. We'll do our best to get to all the questions during the panel discussions. And remember, if you can arrange to talk with a speaker in a separate breakout room. So a novel feature of angiogenesis, the ability for any attendee to reach out to a speaker or any other attendee and arrange for a time to have a video chat meeting on your homepage. Go to the list of attendees and select the person you want to meet. Once they respond, they can set up a time to meet. So please stay tuned with us for session 5, which will be FDA-approved therapies for the treatment of non-exudative AMD. Thank you.